मैं नहीं हूँ क्या? सच तो ये है कि जब हीरोइन स्क्रीन पर आती है तब सब उसी को देखते रहते हैं। Am I right? मैं तो इस फिल्म इंडस्ट्री का सुहाग हूँ। मेरे ना रहने से ये सुहाग उजड़ जाएगा।
Good afternoon, everyone.
Good afternoon.
Shall we start the session, sir?
Yes, I'll share my slide, sir. Please let me know if it is visible.
No, sir, it is not visible. It is showing once. Yeah, now it is visible. I'll quickly introduce, sir. Good afternoon, everyone. I welcome to the today's webinar by Ankura Hospital for Women and Children. Myself, Sailata. I'll be your moderator for today's session. Thank you for joining us for the interactive case-based discussion on interpretation of liver function test. This topic is very relevant to our routine clinical practice. We are pleased to have Dr. Dr Umesh Reddy, consultant pediatric gastroenterologist and hepatologist, with us today. He will be sharing practical insights through real case discussions. Thank you for joining. I now invite Dr. Umesh Reddy to begin the session. Over to you, Doctor.
Thank you for the introduction. I will start the session today. This is basically a basic session mainly aiming at the freshly passed out as well as the residents, because it's a common topic which it is important to know how the liver function test should be interpreted and what role they play in our day-to-day practice. So this is a basic first slide is, I'll start off with this slide where he is basically Prometheus. He's been cursed by the Greek god. So because of which what happens is there's an eagle which tries to eat away his liver daily. So they don't want him to also fast. So the liver which is eaten, it gets regenerated. So that is just to say one property of the liver. So to regenerate. So he then experiences a further pain again. So further pain again. That is the way how the Greek gods cursed him. This is just to show a point on liver, what functions it has. So liver, it has many functions. So some of the important liver functions include synthetic function. By synthetic function, what do I mean is it synthesizes important proteins, important plasma proteins, coagulation factors. So all these normal protein, albumin. So most of the coagulation factors. So these are very important for our daily survival. So synthetic function of liver is important. Detoxification. So many of the drugs, metabolism, all these they get detoxified. Some of the toxic metabolites also. Then bile synthesis and transport. So bile it gets synthesized within the liver, then gets transported through the biliary system. So bile it helps not only in fat digestion and has a role in digestion, but it also eliminates some of the waste, including the bilirubin. Then energy storage, liver stores vitally energy in the form of glycogen, some of the vitamins, iron, etc. Liver immunity. This is a very less talked about point, but liver itself has some immune capabilities. Like the Kupffer cells of the liver, these are the macrophages. When activated, they have a phagocytic function. So liver immunity is also one of the vital function. So how do we need to test the LFT then? So LFT by itself is not a single test. It has many components. No single component can describe the global function of the liver. It's just, for example, not the bilirubin that decides the liver function is right or wrong. So there is no single component. That's what I mean by that. Then it's an important tool LFT still, because sometimes you may just pick up the liver problem by LFT while the symptoms may be just silent. Then interpreting the LFT should always be after a thorough history and physical examination by what we say taking into the clinical context. So these are the different cells within the liver, like the hepatocytes, then you have cholangiocytes, then the smaller ductules in the periphery forming the larger ducts, then comes out through the CBD into the second part of duodenum. So basically, LFT definitely very important in our routine practice. What things it can offer us? See, first thing, if we talk about screening, even a simple child who comes to us in the OPD, he might just come to us with to an endocrinologist, pediatric endocrinologist, saying there is some obesity. And as a general workup, sometimes there might be an LFT which is done, which shows a raised SGOT, SGPT. It itself is good enough for us to pick up the non-alcoholic steatohepatitis. It is the next stage of NAFLD. So non-alcoholic steatohepatitis, which is basically serving as a screening for a later disease which can be directly presenting as an advanced disease also. So as a screening. Then pattern of disease, LFT. So it has GGT also as a component of LFT. I will talk about it later. So I raised the GGT. It serves as this is a cholestatic form of liver disease, not the hepatocellular liver disease. Then regarding severity, especially whenever we talk about an acute hepatitis or an acute liver injury, we need to focus on the INR. INR should also be focused after a vitamin K is given 8 to 12 hours later, because post vitamin K INR is important in deciding the liver and its dynamic in day to day. So whether the liver is getting better or it is getting more severe. Then follow-up. Example, we treat a disease, then we look at the LFT after follow-up. So whatever we are treating, then the LFT has shown improvement. That means it is responding to our treatment. So LFT has important role in follow-up also. The different components of liver function test. This is, I think, all residents should keep in mind here. So what it will include is not just the total bilirubin. It also includes the direct, indirect, obviously. Then SGOT, SGPT, which is then serum protein, serum albumin, serum alkaline phosphatase, and serum GGT. Importantly, PT with INR. I have just kept it in a step-by-step manner so that we will discuss basics on all of this, not in depth, but the basics. So serum bilirubin, what it will tell? It will obviously give us how much is the jaundice severity, but then the total bilirubin is not the only thing to be looked at. We need to look at the direct and indirect fraction. The recent consensus after the 2019 article, 2019-2020 article, which says that we need to consider any direct bilirubin of more than 1 to be significant. So previously it was like out of total more than 20% it was there. If the total is above 5 and then in that the direct should be more than 20% to consider it as direct hyperbilirubinemia. But now irrespective of the total bilirubin, any direct fraction more than 1 is significant to consider, because if it is less than 1, we will say there is no liver injury here. So we need to look at something other than liver, maybe an inherited hyperbilirubinemia, or maybe some other hemolysis. But when direct is more than one, we always have to put our finger on liver. So whether it is primarily the hepatocyte or it could be biliary disease also. But above one, it is significant, especially in the context of neonatal cholestasis, because if you are defining direct more than one as neonatal cholestasis, it itself is a alarming point for us to think in such and such a babies how much workup we require. Then just the bilirubin level, it does not differentiate between hepatocellular and cholestatic jaundice. Say the bilirubin is 10, but there is no feature suggestive of cholestasis. Like for example, you might not have any pale stools, pruritus. So just without the clinical context, without looking the rest of the LFT, just based on bilirubin, we cannot differentiate what type of direct hyperbilirubinemia we are seeing. Is it hepatocellular or is it cholestatic? Then again, whenever there are very high values in bilirubin, always think of, especially if the indirect fraction is elevated, hemolysis, and also rule out any AK or renal failure. Then also look at the rest of the LFT. It is always important that when we look at bilirubin or any other part component of LFT, we always look at the rest of the LFT, because here sometimes the disease might not be a liver disease. It just might be one simple path defect which is resulting in hyperbilirubinemia. Then the second thing which I have combined is the SGOT, SGPT. What are they? They are the enzymes which are markers of hepatocellular injury. That means they are elevated when there is a hepatocellular injury, or simply what we call as hepatitis. Even a 1.5 fold or just elevation, mild elevation is also considered an elevation only. So whenever there is an hepatitis, so then it means that there has to be an SGOT, SGPT elevation. Out of this SGPT, is more liver specific, has a longer T half, but it is not sacrosanct only again to the liver. But SGOT has representation apart from liver, like in the muscle, then in the RBCs, etc. It has both cytosolic and mitochondrial component association. So even if there is strong mitochondrial injury in a given disease, it will rise more than SGPT. Then these SGOT, SGPT elevation, the degree of elevation will not predict the severity. Say a child with acute viral hepatitis has come, he has 800s of SGOT, SGPT. Another child has come, he has an SGOT, SGPT of say 2500. So it doesn't mean that the second child with 2500 is having a more severe liver disease than the one with an SGOT of SGPT of 800s. It is in that situation of acute injury, only the INR will decide. So it does not predict severity in majority of the cases. It can help in monitoring response. We need to also remember that even in primary liver disease, the SGOT may be elevated more than SGPT. This can also be there. We see routinely some cases like dengue, etc., where you can also have representation due to some myalgias or due to mitochondrial involvement. Also, there might be more of SGPT, which is SGOT, which is elevated. Even in a burnt out cirrhotic, by meaning of burnt out cirrhotic means it is an advanced cirrhosis. So in that state also there is not much of SGPT left. So you can have a reversal of SGOT to SGPT ratio with more elevation of SGOT. So these are basic some few points where it will help how the SGOT, SGPT will behave. Then serum alkaline phosphatase and GGT. These are important components with regard to cholestasis. So previously what we have seen SGOT, SGPT are primarily the hepatocellular injury. Whereas alkaline phosphatase and GGT elevation, they are important to tell there is a likely cholestatic condition which is happening. So among these two, again, if you ask one which is more, you have to pick up one, then you have to pick up a serum GGT value, because alkaline phosphatase, again, it can have representation from other sites. Primarily, we are interested in the bone. So in childhood, any value more than 3 times upper limit of normal, we take it as significant because of the growing nature of our children. Then serum GGT elevation, when there is an alkaline phosphatase elevation, isolated, rest of the LFT is normal. You have to know the GGT value also, because ideally when you ask for LFT, you have to have all these components. So LFT includes GGT along with PT with INR. So when alkaline phosphatase is elevated and GGT is also elevated, that will confirm hepatobiliary cause. Then you look at maybe an ultrasound and look at the if there's any obstruction. Is it a choledochal cyst? What is the clinical context? And depending on that, you need to work up. But if the GGT is normal, it is unlikely to be to be a liver disease or a biliary disease, except for some conditions where there is obviously bilirubinemia, cholestasis, alkaline phosphatase high, but GGT can be normal in specific cholestatic liver diseases like PFIC, which is progressive febrile intrahepatic cholestasis, and bile acid synthetic defects. These are little rare, but the common things which we have to remember is GGT elevation is important as a marker of cholestasis. Then serum protein, serum albumin, and INR, they are markers of synthetic function. These are absolutely important. They have very much important role in prognostication. So when acute conditions or acute liver disease we are suspecting, INR is the best prognostic marker, and it is marker of severity. So you have to counsel. There are some King's College criteria and example to say how much INR, how much hepatic encephalopathy, how much so and so is required for a liver transplantation. But if you ask me, even a daily clinical assessment and a daily INR, if you see, and if INR is increasing rapidly, then that itself is an indication for us to be prepared in an acute liver failure to say that liver transplantation may be the definitive treatment which might be required. So the INR decides the treatment, especially in a complicated or liver failure condition. In a chronic disease, however, it is both INR and albumin which are important, because albumin in acute condition will not drop because of its half-life of around 3 weeks. So INR and albumin both become important in a chronic liver disease. Say INR is elevated and albumin is low in a chronic liver disease. It means already biochemically, but that is based on the labs, already a liver, the cirrhosis has started to decompensate. That means the cirrhosis has started to move from a compensated to an advanced stage of decompensation. So many things will be applied. We cannot discuss in a session so much in depth. So I'll just for the interest sake also I'll just describe a few cases how we can go about in an approach whenever there is a liver disease or LFT in hand. So this is a case one, 2-month-old term baby. This baby presented with jaundice since birth. There is no yellowish staining of diaper. Whenever we are asked, we have a child of infantile jaundice or neonatal jaundice, we all will always need to ask about diaper staining. So this diaper staining by mean is a urinary staining of diaper, where the diaper becomes yellowish stained due to the conjugated bilirubin. So if this is there in history, it itself, by history we can say it is basically a liver disease which are dealing with. But this child did not have any yellowish staining of diaper, was exclusively breastfed, feeding well. Weight gain was also good at 2 months. There is consanguinity present. Examination showed some icterus, no organomegaly. Otherwise, gaining weight, feeding well baby. So there is no anemia also. Retic count was normal. So the clinical possibilities which we can suspect a 2 months baby here will be, so because there is no anemia also, it looks like an unconjugated. So step one will be like unconjugated unconjugated hyperbilirubinemia. Then possibly a breast milk jaundice could be one option here. The other things like hemolytic anemia causing some unconjugated hyperbilirubinemia is less likely, given no splenomegaly, no anemia, but and reticon being normal. This was the picture at the LFT. So 8.4 and only 0.6. But what we have to say, as we have discussed, along with bilirubin, look at rest of the LFT. Does it show any possibility that there could be a liver disease? It looks like unlikely, because 3.2 bilirubin in 2 months is albumin in 2 months is normal. In older children, we take 3.5 cutoff. So here even 3.2 is normal, 2 months of age. So everything is looking normal except for the unconjugated, mainly the indirect hyperbilirubinemia. So then we followed it up at 3 months and 6 months. It is still elevated. HB kept on maintaining. So what to do at 3 months? What to do? Usually when there is breast milk jaundice, usually it will last maximum up to usually 3 months. Beyond that, if it is continuing to have unconjugated hyperbilirubinemia, we need to look at other clinical possibilities also. In this case, because of HB is stable, hemolytic anemia is less likely, and it's continuing beyond, even at 6th month it is there. So this child was coming from Vijayawada. So we have done in this child clinical repeat expansion sequence of UGT1A1 for Crigler-Najjar syndrome, and it had come positive. So basically, this will help in prognostication also. So based on the LFT, we could say whether there is any liver disease or not. It did not look like to be there is any liver disease. Then when we followed up, it is unlikely to be breast milk jaundice. Then we had counseled for a genetic testing, which had come to be Crigler-Najjar. So this is a case how we can know whether there is an significant liver disease present or no. On contrary, this is a routine case for a resident in the hepatology clinic. They will see a 2-month-old term. This is a 2-month-old term baby with jaundice again from first week of life. But here there is yellowish staining of diaper. Along with that, there are persistently pale stools. This child is otherwise on breast milk, again feeding well. So birth weight is 3 kg, postnatal weight gain is good, consanguinity again present, icterus is C, there is no apparent cataract because we look at only by torchlight, we cannot tell unless we definitely ruled out through an ophthalmologist. So there is no apparent cataract, there is a firm hepatosplenomegaly. So here what is the possibility? Here it is likely that there is a direct hyperbilirubinemia because of the yellowish staining of the diaper. Once we move beyond this, then what is the likely possibilities? Whether there, because there is pale stools, it could be the biliary cause of cholestasis. In this age, okay, we established neonatal cholestasis in this child, but a persistently pale stools means it is possibly a biliary cause. Matlab, it is not the hepatocellular or intrahepatic cause. It could be primarily a biliary obstruction or biliary atresia kind of thing we need to keep in mind. So the LFT in this child, it showed bilirubin of 7.8, of which direct is more, 4.6. SGOT, SGPT elevated. Protein albumin largely normal. Alkaline phosphate is elevated. Serum GGT is elevated. We also need to keep in mind that GGT in the early infancy can be high. Lab reports may give 50, 90 cutoffs, but even around 140, 150 is okay. But still, this is 408, which is high. In this baby, INR initially was 2.6, but after giving a vitamin K, it was 1.2. So it is not a decompensated liver disease, but it is a synthetic function. That means albumin and INR are preserved, but we can definitely say there is a cholestasis. So this child already underwent multiple tests outside only, and they have come to us in a later date, but I'll just reveal the investigation. So this child had a poorly contractile GB. IDA scan for the child was non-excretory, and then a confirmatory perioperative cholangiogram was suggestive of biliary atresia. The child underwent a Kasai portoenterostomy also. It was a successful Kasai. By that I mean post surgery around 6 months later, they need to have a jaundice less than 2 to say it is successful. At 8 months, that means 5 months later after surgery, the child did not still gain that total bilirubin of 2. But still, we could say successful Kasai because intermittently the child used to pass normal dark yellow to greenish stool. And this kind of attacks in between, which have increased bilirubin in between, were actually the cholangitis episodes, which are well known in a successful Kasai. So what we have done is we have managed aggressively the cholangitis with antibiotics and started a prophylaxis for cholangitis with oral Septran and other cyclical antibiotics, with which the child did not have further cholangitis, and at around 15 months of age, you can see a near normalization of the bilirubin, and we can now confidently tell that it is a successful Kasai. The child started improving and the liver functions almost became normal. And this child also had a low HB afterwards. So we have done an endoscopic evaluation for varices and sclerotherapy was performed. So this case just goes to show that based on LFT, initially we could know that there is a cholestatic condition, and we could think possibly biliary atresia because of clinically pale stools and apparently well-tolerated child. Then once the Kasai has done, the child had repeated cholangitis which were managed, and then after that child showed improvement, and LFT also has normalized. So this is how monitoring can help in a child where there is a chronic liver dysfunction expected. This is a classical third child is a classical case of 5-year-old boy with fever, vomiting, anorexia for 6 days. Fever settled after 4 days, but then jaundice started along with high colored urine. So the child had icterus. There was no overt HE. There was soft and some mildly tender hepatomegaly. So the clinical possibilities in this child will be, this is a classic case of child having prodrome. In the form of usually anorexia, vomiting, pain abdomen, and fever. After that, the child, once fever settles, the jaundice starts and picks up. This is a classical presentation of acute viral hepatitis. So in an acute viral hepatitis, what we need to see is whether it is a complicated in the sense that does the child have any liver failure? Does the child have any cholestatic manifestations? Does the child have any atypical manifestations? At least by clinically, there was no liver failure, no overt hepatic encephalopathy. So at admission, this child had 5.6 of total bilirubin and 2.6 direct bilirubin. SGOT, SGPT, what we need to remember is these are very high SGOT, SGPT, which are typically seen in usually this much of elevation. Say our cutoffs are usually 30 to 40. So American guidelines, even 22, 26 are the cutoffs. So Indian we have not established, but we can say around 30, 35. But these are around, you can say almost 50 times or more elevated. So this kind of elevations of SGOT, SGPT are usually seen with mainly three conditions. First is a classical acute viral hepatitis. This child had fever, so possibly this is the scenario here. So acute viral hepatitis, then ischemic hepatitis. In ischemic hepatitis, usually the bilirubin stays generally normal or not more than 2.5. So the child presented with shock on inotropes. You have a very high SGOT, SGPT, then it may not be an acute viral hepatitis. It is likely an ischemic hepatitis. So acute viral hepatitis, then in ischemic hepatitis, sometimes a drug-induced liver failure or liver injury can also have a high SGOT, SGPT. So these are the common classic conditions where an acute condition due to these kind of insults we need to suspect. Then the other more important in this child will be the INR. And as we see here, the INR is normal. Anything above 1.5 is considered abnormal, especially 1.5 with HE, hepatic encephalopathy, we consider it as liver failure. So this child had a classic presentation of acute viral hepatitis on clinical history, and the LFTs are also in a similar fashion supporting. So there's nothing very specific in this child, but like initially, but why I put this child's details, this was I think an old case from the HGPGI days. So here what we see is that the LFT has shown uh, a normal INR, but the concern was the jaundice was elevated. Jaundice was increasing and there is a HB drop. And if we see, the jaundice was predominantly indirect hyperbilirubinemia that was increasing. So why in this such a child, even if there is a cholestatic manifestation of acute viral hepatitis on the later week or so, usually we need to have an indirect and there should not be, sorry, direct fraction and there should not be a drop in HB. So this child HB dropped and also had mild AKI if I remember. The DCT was negative for the to look into this. Clinical possibility we consider was G6P deficiency because especially in India it's common thing, and whenever there is an acute infection or stress and which because of even vitamin K could have precipitated in this cell, and if that scenario is there and HB drops and the indirect fraction increases, we need to keep in mind conditions like G6PD related hemolysis also. Though sometimes even hepatitis A itself can lead to hemolysis, rarely as an atypical manifestation. Coming to another case, this child was from again Vijayawada. So this child was presented with a 5-year as a 5-year-old boy who had speech delay. He was on speech therapy, had some gait disturbance for 3 months. There was no jaundice, there was no organomegaly, there was no history of any indigenous drugs or native drug Ayurvedic or other medication intake. Elsewhere, they have done some routine blood tests and was referred to here for some abnormality in these blood tests. So, unlikely to come to hepatology, do we feel based on history, but he is actually come to hepatology only because of this LFT. This LFT, it is showing a normal bilirubin, normal synthetic functions. That means albumin INR is normal, alkaline phosphorus GGT is normal, but there is some elevation of SGOT, SGPT. So SGOT of 265, SGPT of 600. There's significant elevation. So we might think what possibility here? We can think of, because elevation is more than almost 10 times, 5 to 10 times elevation, we can still think of acute viral hepatitis. But it is usually an anecdotic acute viral hepatitis we need to think, which is a rare, which is usually, even if we say it is below 3 to 4 years, and there is no prodrome. Always remember in an acute viral hepatitis, unless there is it is like a dictum. If there is no prodrome, it is very unlikely that you have an acute viral hepatitis. You need to have some form of vomiting, anorexia, plus or minus fever, pain, abdomen to say acute viral hepatitis. But still, there is no harm in sending some blood tests, including hepatitis A, IgM. But then this child had something more. So what was this issue? So we asked him to get up from ground. So this child has what is Gover sign. So, and some calf hypertrophy. And the CPK we have got, it is around 15,000. This is just, I put this case to show that liver dysfunction on LFT does not mean only a hepatic disease is there in this child. It means the disease is extra hepatic. Here it is due to the muscle involvement, Duchenne muscular dystrophy. These are again back on neurology follow-up. There is nothing that we can do in this child. So basically what we need to see in LFT is the clinical context also is very important. Then coming to next case, which is a 3-year-old boy. This child was referred for failure to thrive and abnormal LFT. See, most of the times, generally the pediatrician they will be able to handle majority of the liver dysfunction cases, unless if there is a chronic liver disease with portal hypertension, with GI bleed, or some complicated hepatitis. So when there is an abnormal LFT, when the clinical context is not fitting to any of them, sometimes these referrals we see. So what do we need to do in such a LFT is what I wanted to impress today. So when there is no prodrome here, so abnormal LFT, the child has directly come. I'll show you the LFT. But this child again did not have a prodrome of vomiting, anorexia. There is no weakness like the previous child who had a weakness. So this child on clinical examination had no icterus, had some squint. Hepatomegaly was gross in this child. I will say this was 3-year-old. It was almost right iliac fossa, you can say. Maybe I think around 8-9 centimeters I will describe. You can see the bulge on the right side. It is all the organomegaly. Upper abdominal distension, which is almost you can say below the umbilicus on the right side. So this child, when we see the LFT, again bilirubin was normal. SGOT, SGPT elevated, saying that there could be hepatitis, because we are thinking if it's hepatic disease, then there is definitely hepatitis. Then what else? The protein albumin was normal, INR was normal. At least she had good liver synthetic functions. There is no elevation of alkaline phosphatase or GGT. There's no cholestasis findings. Obviously, the jaundice also is not there. So unlikely to be any cholestasis here. So what he has is some hepatitis with significant SGOT, SGPT elevation. But clinical contexts also now we have to apply. So this child, then what we did was we monitored, actually this child did not have the finances also. So at the nearby government medical college, we asked them to be on follow-up, and we have done a morning pre-feed glucose just to know whether there is hypoglycemia. This child had hypoglycemia. Then there is massive hepatomegaly. There is failure to thrive. There is deranged LFT, but with preserved synthetic functions of liver. That is albumin and INR are normal. So we have done basic anti-HIV, IgM, HbS, Ag because the SGOT, SGPT are such high elevated. So that have come out to be normal. So what we need to think in a young child, especially with hypoglycemia as one of the alarming point or a red flag, or you can say the way how we can approach in this child is hypoglycemia has come up. So it is a metabolic liver disease, and with such massive hepatomegaly, it is likely a glycogen storage disease as a first possibility. Other possibilities like fatty acid oxidation defects and hereditary fructose intolerance can be considered. So in this child, we sent the whole exome sequencing, and we can see there's a mutation positive for glycogen storage disease type 3. It is not an uncommon disease. Okay, it is uncommon, but we see as a pediatric hepatology unit, we see at least maybe 2 to 3 in a year. So these kind of cases, they do present with sometimes early morning irritability due to hypoglycemia, maybe some kind of hypoglycemia documentation in the records, some seizures, but mainly as hepatomegaly and deranged LFT. And they can have in type 1 the classic chubby faces. So what we need to do here is treatment wise is cornstarch, which is a slow release of glucose into the blood. So it maintains the blood glucose levels constantly. So cornstarch we give, then we avoid simple sugars. We ask them to buy a glucometer and do a whole glucose monitoring, just like how a diabetic child will be advised. And because of his failure to thrive, some supplements like calcium, vitamins can be added. This was around more than 12 months later. You can see he's gained around good weight. He's gained 3.5 kgs. Liver palpability reduced by 2.5 centimeters. And how quickly you see with cornstarch, his diary, his hypoglycemia sugar diary was pretty much okay. Most of the times it is more than 70. And we see an improvement in his SGOT, SGPT quite rapidly in 3 months. So within a short span of time, if they are very adherent to treatment, it's a good disease in the sense that, but they require follow-up because sometimes they can have filtration defects in the kidneys with proteinuria, some cardiac dysfunction might be there. So we need to keep on close follow-up. So, and it's important also because genetic counseling matters. Then there's another case which I will share here is a 13-year-old. This child came from Khammam. This child presented with jaundice with high colored urine. So this child had dull activity for 1 month. When this child presented to us, he had a little slowness when I asked her some questions. She was little bit daytime sleepiness, grade 1 you can say, or a minimal hitchy. Then there is definitely icterus. Left lobe of liver is palpable more than right. This differential hypertrophy is more classic of cirrhosis, but we may not appreciate it always. But the more important to say a chronic liver disease is the firm nature of the liver on palpation. Okay, so this firm liver was present in this child and obviously supported by splenomegaly. CLD can usually be associated with splenomegaly. Generally is associated, but the spleen, if it is significantly increased, we will be able to palpate it also. So this child had a palpable splenomegaly. So this child presented in around March 2024, had a bilirubin of 6.2 and direct of 4.2. SGOT, SGPT were high. Then protein was 8.8, albumin was just borderline 3.4. And alkaline phosphatase is normal. Cutoff, I don't remember, but 360 should be normal. And GGT is 132. INR is 1.6 even after vitamin K. So this child, you can say, is having a liver failure because if it is above 1.5 and there is along with it HE, but it is not just a borderline. But the importance here we need to look at is whether it is simply if acute viral hepatitis, could it be this prolonged? It is unlikely acute viral hepatitis to be so prolonged. But another important point here we need to look at is the protein is 8.8, albumin is 3.4, the globulin fraction is increased. So this is one marker of chronic liver dysfunction. Okay, especially pointer can favor autoimmune related disease, autoimmune hepatitis. So that is one thing we need to keep in mind. We can send hepatitis A and B because of its commonality, but usually 1 month it is staying in the same fashion. It is less likely to be hepatitis A unless there has been some treatment with some added drugs, indigenous drugs, which can complicate the picture, which is a possibility we need to keep, like drug-induced secondary decompensations. So what we considered, but the acute viral hepatitis in this child is another point which is less likely is because of the firm liver and splenomegaly. Sorry, I did not comment on these 2 points. So acute viral hepatitis based on LFT, we cannot rule out, but clinically when we say the firm hepatomegaly and splenomegaly will rule out acute viral hepatitis. So the clinical possibility here is a chronic liver disease. So we usual chronic liver disease suspects in this age group. Wilson above 3 years, we do suspect. Autoimmune hepatitis is in close DD. Then hepatitis B, C, we need to consider and test. So when we do the workup for these disorders, we do it simultaneously, not one after the other. So we do KFring, ceruloplasmin, urine copper. They have come negative. Hepatitis B and C has come negative. IgG has come elevated. Anti-LKM has come positive. And to confirm, so this is moving towards acute autoimmune hepatitis. So when there is suspicion of autoimmune hepatitis, to prove it, because there is no one specific test to say, though LKM is very specific, but still to prove it, we need a liver biopsy. So this is a liver biopsy which showed features which are classical of autoimmune hepatitis, like the interface hepatitis. And infiltration of the liver with increased dense infiltration of lymphoplasmacytic infiltration. So this kind of interface hepatitis is important. So this child had features, even emperipolysis, which is very rare. Even we could not find in our residency time. They have mentioned here they could see an emperipolysis also. So these are features which are consistent with autoimmune hepatitis. So we started this child on steroids. Usually a type 2, maybe around 70% can respond, 30% may not respond, but still good for everyone that child responded to steroids or LFT normalized. Then now she's continuously on follow-up with us. She now is having regular menstrual cycles. She's going to school. Her fibroscan, I think it has 8 kilopascals. I don't remember if they got it done again recently, but the rest of the liver functions, as you see, have completely become normal. So this goes to show that on prompt identification and treatment, and importantly compliance, because they have a medical background, they could understand the disease and they have continued treatment, which is important. And this fibrosis of 8 kilopascals is not very high. I think if you repeat at this time, it will possibly have shown even significant improvement also. So basically this shows that how the liver function test helps in follow up. It will show that, okay, whatever we have tried the treatment here for autoimmune hepatitis, it has shown significant improvement. This GGT elevation in this child, if we ask the question, that is due to the overlap. The autoimmune hepatitis can have an overlap of autoimmune sclerosing cholangitis also. That is why there is a picture of high GGT. When that such a picture is there, we need to give them the treatment with ursodeoxycholic acid also. So I'll conclude by saying that liver has many vital functions. A single component cannot identify all liver functions. So there is a gamut of liver components which come under one term of liver function test, which also includes, I will always press to the residents that there has to be a serum GGT along with it a PT with INR to come under LFT bracket only. And each of these components, they have their own specific importance. Liver function test should always be interpreted with the clinical context. Abnormal LFTs can sometimes be due to non-liver related disease, like we have seen in that child with the Duchenne muscular dystrophy, where you can see an abnormal LFT. LFTs in general, they help in screening to know the nature of involvement, to help in the severity or prognostication, as well as in treatment monitoring. I will conclude by just putting a photo of one or two kids to just say how clinically they present, how the LFTs behave. This child was just a northeastern child. You can see some facial discoloration, yellowish discoloration. Also, there is some discoloration in the arms and soles. So we have done basic workup for this child, including LFTs. LFTs have come normal. So what do we then progress in this child? We have not encountered such a scenario like in the previous slides when we have discussed that, okay, SGOT, SGPT is elevated, but the disease is not in the liver. But here there is clinically jaundice, but LFT is normal. So one thing we can do, we can repeat from another lab also, but just to add, but I will say that this is a case, an interesting case of keratonemia. Yes, I think Dr. Shrevanti has put it here. So this child was taking excess of these sweet potatoes, not excess predominantly on sweet potatoes and carrot. So we just ask them to keep a control on that, and then this discoloration will get away. In literature, it has mentioned even few months also it will take. So we've attached to a dietitian with us. Then this is a child who came to my OP last 2 months back. This is an interesting case where this child presented actually to hematology because of pancytopenia. But pancytopenia is there. Even some advanced tests were done, but basically it is not a hematological disease. Then this child went to a neurologist who identified. I am asking her to do a star making to assess her higher functions, and it is important for HE also, evaluating HE. You can see her handwriting has changed a bit. Mother complained this part also predominantly that she is trembling and having some tremors. So they went to a neurologist, and neurologist had done an MRI and also an ophthal evaluation, and ophthal evaluation had picked up had picked up a KF-free. So this is just to say that they can go to hematology department also. The reason for hematology department in this child, the pancytopenia, is because of the hypersplenism. So hypersplenism is a feature of CLD. Depending on the splenomegaly and advancement of portal hypertension, there will be hyperspenia, and it will directly relate relate to the it will directly relate to the um, pancytopenia. So basically, this is basically to just show that how clinically also we need to keep in mind how the LFTs also have to be decided based on the clinical context. So I would like to conclude my talk here. And if there are any residents, we can have a discussion on LFT or any hepatology discussion also. It is welcome.
Sir, we have a quick Q&A questions. If anyone having any questions, you can text or a chat box so that doctor will reply. Any questions, please?
I have seen some active participation, especially the keratinemia. So there can be any general questions also. If some hepatology, if you feel that this point will be discussed, it will be better. So we can have a discussion if there are any.
So we got one question that how frequently can you repeat vitamin K dosage?
Yes, yes. So this is a good question. Basically, vitamin K, the definition even for to say whether post vitamin K we had a response is best based on a single dose only. So even after one dose of vitamin K, if there is no correction of INR, then that means that it is likely an underlying liver disease, not a vitamin K deficiency. So it is a liver disease, so it will not get corrected even if you go n number of doses. But usually you can, especially if there is recently a significant antibiotic intake, vitamin K you feel is really deficient, even though there's a liver disease also, you might go for 3 days. So in infancy, you can consider between 2.5 to 5 mg, and older children between 5 mg to 10 mg. Ideally, 1 day is enough. What I am saying is a single stat dose, but you can consider giving 3 days also at a stretch. After that, it will usually be, for example, a chronic liver disease. So where you expect that there will be some, so vitamin K can be given even weekly also, even cholestatic disease especially. Cholestatic liver disease, you have to give vitamin K because they will be deficient in vitamin K because of the decreased amount of bile and decreased fat soluble vitamin absorption. Cholestatic disorders, every week you have to repeat. But in an acute condition, stat dose, one dose also sufficient, or up to 3 days, each day one dose for 3 days.
Any other questions?
Any other questions? Many residents are only, I think, they're here. I see some of the names I could recognize. So I don't want to put them the questions. So just they can ask me if there's any question, because this is a very common topic, liver function test, where I think when we order liver function test, we sometimes even don't think of GGT and IPT with INR. That thing I wanted to impress. The rest of the things, how you have to approach, I think I've given 4 or 5 different kind of scenarios or cases where how we need to approach and how fast we need to act. I think this is another good question on dietary restrictions in acute hepatitis. This is an absolutely good question because even at basic level, even at our basic teaching level, usually we ask them don't be on bland diet. Bland diet means no oil, no mirchi, just rice and some idli, etc. So that is called bland diet, or some juices. So if you give, we should not ask them to be on bland-aid. First thing. Second, we should not ask them to take any juices, this kind of Glucon-D and other things. So this is the first no. Then what we need to encourage in these children with acute viral hepatitis or these kind of patients is to take a normal home-based diet. The reason being, there is no, obviously, if there's hepatitis A is the cause, for example, there is no treatment for hepatitis A. The only way the body will be able to get enough immunity and clear the virus is when you give good nutrition. So when you supply good nutrition, the liver recovery helps. Otherwise, there is no antiviral, of course. So the overall body nutrition is important for liver getting help to clear the virus. So a normal home-based diet without all these things which I have told. There's no bland diet, no juice, and no Glucon-D. These kind of mistakes usually sometimes, especially the grandparents, they will say jaundice is there, so don't give oil, haldi, mirchi. So these things should ideally we should tell them prior only before discharge that there's no medicine. We may give Udiliv and other ursodeoxycholic acid, sorry, and other things, but the prime thing is nutrition. We need to always focus on that, telling that diet is important, because if the liver recovery slows, there may be complications like slow recovery of jaundice, cholestatic phase, sometimes a recurrence or relapsing hepatitis. So unnecessarily the complications can come up. So we need to focus on diet definitely.
So we got one more question. Any restriction on protein intake in diet?
No, if you are thinking about like if there's an underlying amino acid or some metabolic liver disease which is amino acid or protein related, their specific diets will be there. For example, child with urinary cholestasis has tyrosinemia. There we need to eliminate obviously phenylalanine and tyrosine to the minimum level and order and procure specialized formulas which some specially we can procure from some of the dietary companies. So that kind of picture will be there if it's a metabolic liver disease associated with protein or amino acid level. But if it is not that, if it is, for example, acute viral hepatitis or acute hepatitis, then there is no restriction unless there is a liver failure. Even in CLD, there is no restriction unless there is liver failure, where we will advise them not to take, especially with hepatic encephalopathy, not to take animal protein. So animal proteins can increase the mercaptans and other things which can increase the ammonia and ammonia related damage, and more HE can worsen. So HE can worsen. That is why we should be careful when the child has an HE. That means when the child has liver failure. If there is no liver failure, uncomplicated hepatitis, then we can take the normal age appropriate protein. In a CLD, actually we ask them to take daily egg. Of course, if there is no hepatic encephalopathy, daily egg or daily good amount of protein, because their synthetic functions are already low. They may have some ascites, their albumin is low, so we need to give good protein. There's no restriction on protein, especially in a CLD, unless obviously when there is hepatic encephalopathy.
Any other questions?
I think post lunch, I think that is also. I think it's a good thing that they have asked some questions at least. Ultimately, I think Dr. Shravanti had asked. Others can also ask, because they can share their own experience also. There's some case which you have thought something else has come up, then you have treated your experience on a case or an LFT or any gastro hepatology, especially hepatology today is a discussion. So liver related case can be discussed. These are specific points and questions which on diet are important actually. Definitely. I think somebody asked.
I think no one has any questions.
Okay. If there are any more questions, you can just contact the chat. You can put in the chat box. We will contact and let you know back. That can
Yes,
be
yes, yes.
definitely.
Thank you, sir. Thank you so much for valuable insights.
I thank our Ankura group and all of you for the smooth conduction. Thank you.
Thank you, sir.
Thank you. Yeah. Bye.